Hi, this is Pat Posa. I'm a quality excellence leader in the St. Joseph Mercy Health System in Ann Arbor, Michigan, and we're going to talk today about preventing catheter-associated UTIs and UTIs in the skilled nursing facility and long-term care. So why is this important? Well, we know urinary tract infections are some of the most common hospital-acquired infections, along with other device-associated infections like central line-associated blistering infections and ventilator-associated pneumonia. They account for about 25% of all hospital-acquired infections. As well, in nursing homes, urinary tract infections, pneumonia, upper respiratory tract infections, skin and soft tissue were ranked as the 3 greatest infection challenges in skilled nursing facilities. 70 to 80% of UTIs are related to urinary catheters. 5 to 7% of nursing home patients are catheterized. 12 to 15% of new admits to nursing homes are catheterized. So one of the strategies is, upon admission to your facility, is do you have a removal protocol, and to assess necessity upon when they come to you, and then get that catheter out. It leads to increased morbidity and costs, and in the hospital, Medicare is no longer reimbursing us for the additional cost associated with caring for a patient that has a UTI. And then it's also included in the value-based purchasing program. And most importantly, CAUTI prevention is part of a 2012 National Patient Safety Goal. When we think of CAUTI, we have to think beyond just the infection and look at the harm that can be caused by just having a urinary catheter in. And that's what this picture is displaying. You can get a CAUTI, but urinary catheters can also lead to pressure injury or skin injury, either from the catheter itself, the patient laying on it, or the fact that if they have a urinary catheter in place, they might be less likely to mobilize around and get up and moving. You see increased length of stay, the immobility, just patient discomfort, trauma to the meatal area. And then related to immobility, the patient will become deconditioned and then increase the risk for falls, as well as having the device in and they get up and they trip over it, or the lack of immobility, and it increases their chance for venous thromboembolisms. So let's talk about how a urinary tract infection occurs when you have a catheter in place. So the source of the bugs are colonic or perineal flora, and it's usually on the hands of personnel. Microbes enter the bladder either extraluminally, so around the bag and the catheter. And so you'll see that our strategies are targeted at knowing that this is where the bacteria enters. So, for example, it can crawl up the outside of the bag. So a number of facilities, you have to ensure the bag's not, urinary catheter bag is not on the floor. Some people put them in special sacks so that they don't get contaminated or get exposed to the environment. Also, you can get the bugs in through the inside of the catheter, and that's why it's important not to break the seal. And so we try and keep that closed. And then the contamination can also occur during insertion. One of the things that we do know is that when you have a urinary catheter in place, you have a 3 to 10% increased risk of developing bacteria with that catheter in place. So if it's in for 3 days, you are going to get 100% chance, well, actually a 30% chance. If it's in for a month, then you have a 100% chance that you're going to have bacteria in the urine. And we'll talk more in a few minutes on that. When we treat an infection, it has to meet certain criteria to be an infection. Having bacteria in your urine doesn't mean you have an infection that needs to be treated. So our overall goal in preventing catheter-associated UTI is to disrupt that life cycle of the urinary catheter. Step 0, the first thing is to avoid catheter if possible. If you're putting a catheter in, you need to do it aseptically and ensure that people are following the appropriate procedures. And then you need to maintain awareness and proper care of the catheters. And then you want prompt removal when it no longer meets indications that a urinary catheter should be in place. So step 0, how do you avoid placing a urinary catheter? Well, you should consider these alternatives. Bedside commode, urinal, continence garments to manage incontinence. There are great pads for the bed, and we'll talk about external devices to assist with urine collection in patients that are incontinent or in which you want to monitor the urinary output. Bladder scanning to assess or confirm urinary retention prior to replacing or placing a catheter. Straight cathing, if there's some retention and you think that it's possible to not have consistent retention, and then using external catheters. And we have a number of external devices for men, and there are now a device on the market for a woman. So what did the guidelines say? That the indications for placement include perioperative use for surgical populations, urine output measurement in critically ill, management of acute urinary retention and urinary obstruction, assistance in pressure, injury, or ulcer healing for an incontinent patient, and then for comfort at the end of life. So if someone is in hospice or comfort care. So these are the indications. They have been developed through expert opinion, and these are the indications as if someone's coming to your facility with a urinary catheter in place, if they don't meet one of these indications, then you should promptly remove it. Other recommendations for preventing catheter-associated UTI include only leaving the catheter in as long as needed, ensure that staff is properly trained to insert and maintain the catheter, using aseptic technique and sterile equipment, use alternatives to indwelling catheter, maintain a closed drainage system, secure the system, maintain unobstructed flow, and keep the collecting bag below the level of the bladder. We're going to talk a little bit about each of those. For insertion, you can see here, this is a very simplified insertion checklist. If you have techs inserting your urinary catheters, consider if they've been checked off for competence. In most of the hospitals, they've moved away from techs putting in urinary catheters to that being an RN function, and to check competency even of RNs in doing it. Especially in females, it becomes difficult maintaining that sterile field when you're trying to insert the catheter. So some institutions have made that insertion a 2-person procedure. Using alternatives. Let's talk about alternatives that are out there. We've known for a long time that we have condom casts available for our male patients, and there's a whole host of them at a variety of sizes. There's some common problems with external collection devices. often skin irritation and maceration. It's difficult to keep the condom from falling off, especially if there is a very short shaft or retraction of the penis. If it's put on too tightly, you can have ischemia and obstruction, and to get it to adequately adhere, you need to ensure that it's secure on the shaft of the penis and there is adhesive mechanisms, and those are often a challenge. So I would encourage you to test out the current condom casts that you have in your facility, and instruct people on how to use them properly, and so that they stay on for extended period of times. There's a newer catheter on the market, and this is a hydrocolloid alternative, and it doesn't hook onto the shaft of the penis, it hooks onto the glands, and the hydrocolloid wafer shaped adheres and acts the glans penis and acts as a skin protectant. The seal is reinforced by a second hydrocolloid strip, and it can be used in circumcised or uncircumcised. And you need to make sure that you've cleaned it with a remover and alcohol prior to placing it. This is a study of before and after a QI project of its impact on wear time. So they did a comparison and monitored wear time and evaluated the skin, and found that they saw a significant decrease in Foley utilization rate after they introduced this product. So the message here is to ensure that you have a good external male catheter device, external device, so that you don't have to put in an internal. And what they found is that the wear time for this was longer than the typical condom cath. It was greater than 24 hours. Something newer to the market is a female external device. You can see it pictured here on the right, and it sits in the perineum, and it's attached to suction, and it gently wicks away the urine in a patient who is incontinent. A small study was done at a hospital in California, pre-post, and they, in 2015, they had 6 female CAUTIs, and they had none in 2016. So they were able to reduce the indwelling catheters in the female by having the ability to use this external device. And there was good RN satisfaction. So this is something that we'll see more of, I think. But so it's something to look at. So some key elements to look at when you're considering the use of external collection devices are displayed here. So indications at the top, and then recommendations for improving the use of external collection devices as an intervention bundle for preventing the use of catheters. So that's there for your review. So as we move on to other standard recommendations to prevent catheter-associated UTIs, we want to be able to maintain a closed drainage system and secure the system appropriately. So here are the different securement devices, and if you're still using the device that's on the bottom left, it's a Velcro that attaches around the thigh. The difficulty with this device and why this shouldn't be your securement device is that it's the whole band can move up and down the leg and therefore cause trauma and pulling on the catheter. So you should be using one of the other securement devices if you have a urinary catheter in place. The final recommendations are to maintain unobstructed flow and keep the collecting bag below the level of the bladder. And that's, you can do that through, making sure there aren't pendant loops, and then ensuring as you're getting the patient up into the chair that has a urinary catheter that you continue to keep it below the level of the bladder. And especially if you're going to mobilize, it would be great to empty the bag prior to getting up. How we bathe patients can impact central or catheter-associated UTIs. Bath basins are a potential source of infection. This is studies in a hospital, 88 hospitals, and they looked at 1,100 basins and found that the majority of them were colonized with not nice bacteria. How do the basins get contaminated? They get contaminated with skin flora. They're often used for multiple things, incontinence cleaning, emesis, product storage. And when you're using a basin to bathe, you're also then using tap water. And we know that there's a bacterial biofilm in most pipes, and that can harbor bacteria, and there are a number of studies demonstrating the association of hospital-acquired infections with outbreaks of with water transmission. And so it's transmitted during drinking, bathing, rinsing items, contaminated environmental surfaces. And it's the hospitalized or immunocompromised patient that's at the greatest risk. You and I, there's probably biofilm in our pipes at home, but we are not immunocompromised, and we have good mechanisms to battle those. So this is a study of moving from basin bathing to basinless bathing. And they, again, this is a hospital study, and they decreased their catheter-associated UTIs significantly. And you can see the trend line there, an 89% reduction. Here's a reverse study where they had been basinless, and then they moved back to using a basin, and they saw their catheter-associated UTIs increase significantly. Often the prohibitive, what prohibits people to move to basinless bathing is the cost. And so here is a study that looks at the cost of prepackaged bathing washcloths, basin and water, and then taking into account additional product costs, UTI, length of stay, et cetera, and demonstrated that even though the product cost was more, if you looked and put in the longer length of stay when you get a CAUTI and the average cost of a catheter-associated UTI, the basinless bathing was cost effective. So how do you clean a patient with an indwelling catheter? Indwelling catheter care should occur with a daily bath. As a separate procedure using clean technique. There's really no evidence to support doing it more than with the daily bath, except is if you have liquid stools, then you should bathe the patient. Again, use separate cloths to clean front to back in the perineal area, and then also clean 6 inches of the catheter from the insertion 6 inches back, and apply barrier cloth to the skin so that you get good protection. So we know that even if you're on the right track, you're going to get run over if you just sit there. So you need to continually assess whether or not these practices are in place, what new practices continue to be out there, so that you stay on top of the evidence. In the catheter-associated UTI update in 2014, they also talked about when to replace the catheter and when there's a break in aseptic technique, disconnection, or leakage. And then they focused on for examining and getting fresh urine, collect a small sample by aspirating from that needleless port. Also, you should develop a protocol for managing, and now you're not going to see this much in the skilled nursing facility, but urinary retention. Don't use antimicrobial impregnated catheters, do not routinely, and don't screen for asymptomatic bacteria. So sending urine cultures on everyone is not what you should do, because as I shared before, you're going to have bacteria if that catheter, you get see a 3% increase each day it is in. And so you have it in for an extended period of time, you're going to have bacteria. So I'm going to switch our topic and talk about preventing UTIs. So if someone doesn't have a catheter and your goal in your facility is to take those urinary catheters out, but what do we do to prevent UTIs, which is a common infection in nursing homes, even if a person doesn't have an indwelling catheter? So the 4 strategies are to ensure adequate fluid intake, and that's either recording I&O, but oftentimes you're not doing a consistent record of their intake, but you can evaluate if they have adequate intake by examining their urine, and it should be light and clear. And so this is something to educate the CNAs about, and especially in the warm months of the year, to ensure that there's adequate hydration and that they evaluate the urine of the residents. Adequate toileting can help prevent UTIs, so to prevent retention. So bladder should be emptied every 2 to 3 hours, and so putting patients on a toileting schedule. Ensuring that both the patients as well as the staff ensure that they're cleaning appropriately front to back. And one of the items that we often forget is we focus on hand hygiene of the healthcare workers, but don't encourage hand hygiene for our residents. And so hand hygiene before meals, after meals, as well as hand hygiene after they've gone to the bathroom, ensuring that that is happening and available. And then needing to manage incontinence with appropriate toileting products. I'm going to spend the next few minutes talking about strategies to not overtreat asymptomatic bacteria, which is a common problem in nursing homes. So antibiotic use in nursing homes is significant. Between 50 and 70% of nursing home residents will receive at least 1 course of systemic antibiotics during a calendar year. 20 to 30% may receive multiple courses. And frequent use of antibiotics assists in producing those resistant organisms. So in a recent study, more than half of the prescriptions for antibiotic for a suspected UTI were for residents that were asymptomatic. And so there's no evidence that indicate antibiotics help in asymptomatic bacteria. And actually there's evidence that it can harm the patient from creating that multi-resistant bug and also setting them up for C. difficile. So the most recent trends in healthcare-associated infections is the growing incidence of community drug-resistant microbes, and they are a threat to more than just the patients or residents in the nursing home. Bacteria can migrate to the caregivers as well as to family members, and they can take it back into the community. So what are some of the guidelines for antibiotic use? Well, these guidelines are based on evidence, and the researchers developed guidelines for a few key infections, and one of them was including UTI. And other researchers independently used these guidelines, tested them, and found them that they were effective in reducing the numbers of antibiotic use. So here is one of the criteria, and this is supported nationally, and so it's the ABCs for diagnosing UTI. And you can see here in the center that to diagnose a UTI in long term requires both clinical signs and symptoms of a UTI and a positive culture. So you have to assess for clinical signs and symptoms. If they don't have these, then there's no reason to test the urine. So if the person does have the clinical signs and symptoms, then you get a clean catch, and you can consider getting a CBC, and then you'll examine your urinalysis and your culture. But if I have the criteria for a UTI with symptoms and a positive culture, then I'm going to treat with antibiotics. But if I have a positive urinary culture, but I don't have those symptoms, then I need to look for another reason why maybe they have a fever, monitor their vital signs, and increase the fluid intake if necessary if I find that they don't have sufficient fluid intake. So prior to treatment, ensure that that is in alignment with their advanced directives. And if you're noticing a mental status change, have you looked for other possible causes? So this is something that would be important to institute in your facility. And there's another tool that's available also, and that tool is UTI SBAR, and this is available from the AHRQ website, and it's intended to guide communication by the staff at the facility when talking to the physician, and it's based on SBAR, which is Situation Background Assessment and Recommendation. It is based on clinical practice guidelines. So this is what SBAR is. You talk about the situation, what's going on now, what has happened, background, what you found and what you think is the assessment going on, and what you want done is the recommendation. And so here is a tool that you could institute in your facility that basically walks the nurse through key elements before they're talking to the doctor, so that they collect all the correct information and then talk to the doc. And it includes that criteria that we just talked about on when you should treat a UTI. So it's important in your facility to do a current state assessment of how well these evidence-based practices that I just shared with you are in place. And so here is a tool for both patients without an indwelling catheter and with an indwelling catheter. You should look to see if you have current policies in place. And then you should audit patients with urinary catheters to see if those evidence-based prevention strategies are in place, and how you're handling patients without urinary catheters as well. UTIs are one of the most common infections in nursing home residents. Quick removal of the urinary catheter when they don't meet insertion criteria is important. Putting something in place when they first get admitted is a great strategy to get it out right at the beginning. Implement evidence-based practices for insertion and care of urinary catheters, audit those prevention practices, don't treat asymptomatic bacteria, and educate patients and families on how to prevent catheter-associated UTIs as well as UTIs. And thank you very much.